Welcome to the deep dive. Today we're zeroing in on a chronic skin condition, one you'll definitely want to get your head around, especially if you're prepping for exams like the MSRA.
Absolutely. We've taken the key info on discoid eczema, or nummular eczema as it's also known, from the materials provided. The idea is to really give you the high-yield stuff, the core knowledge you need for this topic.
Right, kind of a focused revision session. We'll cover the essentials, what it is, the causes, who gets it, what it actually looks and feels like, crucially, what else it might be.
How to diagnose it, manage it, the prognosis, and any potential complications too.
Exactly, giving you that clear, structured overview. Ready to jump in?
Let's do it.
Okay, first things first. What exactly is discoid eczema?
So fundamentally, it's a chronic inflammatory skin condition. The name itself is a big clue. Discoid or nummular means coin-shaped. You're looking for these very characteristic round or oval patches on the skin.
Coin-shaped. Okay, so visually quite distinct then.
Very distinct. They're typically red. They're usually very itchy and scaly. And a key feature is that they are well-demarcated. They have sharp, clear borders.
Sharp borders, like a coin's edge almost. Got it. And where do these patches usually show up?
Most often, you'll find them on the limbs, so arms and legs. The distribution is often bilateral, meaning both sides of the body are affected.
Both sides. Symmetrical then?
Well, interestingly, no. It's often bilateral but asymmetrical, so you might see, say, 3 patches on one shin and maybe just one on the opposite forearm.
Okay, bilateral but asymmetrical. That's a useful point. Who tends to get this? Is there a typical patient profile?
It can affect different age groups, but it's definitely more common in adult males. And there's a specific association worth remembering.
Oh, yeah.
Yes, a link with chronic alcoholism, specifically in men over 50. It's quite a specific point highlighted in the sources.
Wow, okay. Chronic alcoholism in men over 50. That's definitely one to file away.
It is. It's not the only factor, obviously, but it's a recognized association.
Right. So that's the what and the who. Let's talk about the why. What actually causes discoid eczema? What are the risk factors?
Well, the cause is generally described as multifactorial. So it's not just one thing. It's likely a mix of genetics, environmental influences, and the way the immune system is behaving. Think of it like a few different things needing to happen at once.
A perfect storm scenario.
Kinda, yeah. Multiple elements coming together.
Are there specific triggers? Things that can set off a flare or make someone more prone to it?
Definitely. Things like a localized injury, a cut or scrape can sometimes trigger it. Skin infections like impetigo, contact dermatitis from something irritating, and importantly, dry skin. That's a big one. Even varicose veins are mentioned as a potential factor.
Dry skin keeps coming up with eczema, doesn't it?
It's really central here. Dry skin is a major risk factor. Other things that put you more at risk include a personal or family history of other types of eczema, like atopic dermatitis, exposure to irritants, stress, and even the weather.
The weather? How so?
Cold, dry weather tends to make it worse, which ties back into that dry skin issue,
Right.
whereas warm, humid conditions often seem to help. Also, specifically for lesions on the legs, problems like venous insufficiency, poor circulation, or stasis can really aggravate things there.
That makes sense, linking back to the common location on the legs.
Exactly. Oh, and one more, less common association mentioned is that severe cases can sometimes pop up after treatment for hepatitis C with interferon and ribavirin. It's rare, but noted.
Interesting. Okay, so we know why it might happen. How about the actual mechanism? The pathophysiology. What's going wrong in the skin?
The core issue is a breakdown in the skin barrier function. Imagine your skin's outer layer as like a protective brick wall.
Okay, a barrier keeping bad stuff out and good stuff in?
Precisely.
Yeah.
But in discoid eczema, that wall becomes leaky. It's compromised. So what happens? Water escapes more easily, leading to dryness.
The dryness again.
Yes.
Yeah.
And at the same time, because the barrier's weak, things from the outside irritants, allergens, maybe even bacteria can get in more easily.
Ah, so it's a two-way problem. Water getting out, irritants getting in.
Exactly. And that penetration of external stuff combined with the inherent barrier defect triggers inflammation and immune system responses within the skin. That's what causes those red, ishy, coin-shaped patches to form and persist.
So the leaky wall lets trouble in, causing inflammation behind it. That paints a clear picture.
Yeah, hopefully that helps visualize it.
Let's talk numbers. Epidemiology. How common is this condition?
The estimate is around 2 cases per 1,000 people. And as we mentioned, it is more common in men. There's a peak age for men noted between 50 and 65.
So primarily older men.
Well, that's one peak. But interestingly, there's a second peak described in women, typically much younger, between 15 and 25 years old.
Oh, okay. So two distinct groups, older men and younger women. That's really key for pattern recognition, isn't it?
It really is, and it's noted as being rare in children, so knowing these age and sex distributions can be a really helpful clue when you're considering diagnoses.
Definitely helps narrow things down. Now let's get to the clinical picture, what you actually see and what the patient feels. Clinical features.
Okay, so we've got the key visual. Those round or oval, red, inflamed patches with the sharp, well-defined borders. The coin shape. And the feeling. Typically, intense itching pruritus is a major symptom. And the patches themselves feel dry, often scaly.
Do they just suddenly appear as perfect circles?
Not usually. They often start out smaller, perhaps as little red spots, maybe with tiny bumps or even small blisters, vesicles. These then tend to kind of cluster and merge together, expanding outwards to form those larger characteristic patches.
Right. Small spots coalesce into bigger coins.
Exactly. These patches can look quite swollen. They stay round and often develop a sort of crusty surface. Size-wise, they're often around 1 to 3 centimeters, but they can definitely get bigger.
Are there any variations in how they look?
Yeah, sometimes the inflammation in the center of the patch can start to fade, leaving skin that looks more normal in the middle. This gives it a ring-like appearance.
Ah, and that's where the confusion with ringworm comes in, I bet.
Precisely. That central clearing can really mimic tinea corporis. And speaking of appearance changes, a really crucial sign to look out for is a golden crust developing on the surface.
Golden crust. What does that signify?
That's a classic sign of secondary bacterial infection, usually Staphylococcus aureus. That's a really important clinical pearl.
Golden crust equals likely staph infection. Easy to remember.
Definitely. Location-wise, we said limbs are most common, but it can occur pretty much anywhere except typically the face and scalp. And revisiting symmetry, while the number or severity of patches might differ side to side, asymmetrical, you often find some lesions present bilaterally.
And the itch, you said intense.
Yes, the pruritus is often described as severe, and it's characteristically worse at night. This can be a major issue for sleep and just general quality of life.
I can imagine. So let's paint a quick picture, a mini vignette. Say a 6-year-old man presents. He's got these incredibly itchy, coin-shaped, red, scaly patches on his shins and maybe his forearms. They started small, grew bigger, have really sharp edges. He says the itching is unbearable at night and seems worse in the winter.
That sounds pretty spot on, right?
That scenario hits almost all the key points. The typical demographic, the location, the classic appearance, the progression, the intense nocturnal itch, even the seasonal variation. Yeah, that's a textbook presentation of discoid eczema.
Great. That mental image really helps solidify it. But as you hinted with the ringworm comparison, it's not always that simple.
Yeah.
What else could cause round red patches? Let's talk differential diagnoses. This is vital stuff.
Absolutely critical, especially for exams. Getting the diagnosis right matters for treatment. So, tinea corporis, ringworm we mentioned, what are the giveaways for that? The sources mention things like fewer vesicles, often a raised kind of narrow border, an active edge and scale that's more concentrated on that raised border or plaque itself. That seems quite different from the usually flatter, though well-defined, border of discoid eczema.
Exactly. That raised advancing border is very suggestive of fungal spread. Okay, what about other types of eczema?
Well, there's asteatotic eczema, sometimes called eczema craquelé. That tends to be more about generalized dryness and cracking, often on the lower legs in older people, looking a bit like cracked pavement or porcelain, not so much discrete coin shapes.
Right, and atopic dermatitis.
Usually different distribution flexures, like inside elbows, behind knees, and the lesions themselves aren't typically those perfect, well-defined discs.
Good points. How about contact dermatitis?
With contact dermatitis, you'd expect the rash pattern to clearly map onto where something touched the skin, like a reaction to nickel in a belt buckle or an adhesive patch. Discoid eczema doesn't usually follow such specific external patterns.
Makes sense. Lichen simplex chronicus.
That's described as thickened, maybe slightly purplish, violaceous skin from chronic scratching or rubbing. But the key differentiator mentioned is that it has no clear border. It just sort of fades out. That immediately contrasts with the sharp demarcation of discoid eczema. So that clear border is a real defining feature of discoid.
It really is. Then there's stasis dermatitis.
Okay, that happens with venous insufficiency, usually on the lower legs, so the location overlaps with discoid. But stasis dermatitis often looks more like diffuse redness, swelling, maybe some brownish staining hemosiderin around the ankles. Not usually those distinct coin shapes, though sometimes overlap can occur. Look for other signs of venous issues.
Right. Look for the bigger picture of venous disease. And finally, psoriasis.
Psoriasis often prefers extensor surfaces, elbows, knees, plus scalp, lower back, and the scale is typically much thicker, silvery, and more stuck on compared to the finer, drier scale you usually see in discoid eczema.
Okay, great distinction. So, quick test. Patient has coin-shaped patches, but you also notice a raised, narrow border with scale concentrated right on that border, which is the least likely diagnosis. Discoid eczema, tinea corporis, or psoriasis.
Well, that raised border with scale really shouts tinea corporis. It doesn't fit the typical description of discoid eczema or psoriasis nearly as well. So discoid eczema would be the least likely in that specific scenario.
Exactly. Knowing those subtle differences is key. All right, how do we confirm the diagnosis? Do we need lots of tests?
Actually, no. The diagnosis is mainly clinical, based on the history you take and what you see on examination. Often that's enough.
Good to know. So when would you do investigations?
Skin biopsies aren't routine. You might consider one if the picture is really unclear, if it looks atypical, or if you strongly suspect something else like psoriasis or even something rarer and need tissue confirmation. But the source's stress, it's usually not needed.
Okay, so biopsy is reserved for tricky cases. What about other tests? Well, you see that golden crust we talked about.
Suspect infection.
Exactly. You take a bacterial swab to check for Staph aureus or other bacteria. And if you're seriously considering tinea corporis as a differential,
Scrape for fungus.
you got it. Skin scraping sent for mycology. And patch testing. That can be done if you think a contact allergy might be playing a role, but often a specific trigger isn't found in discoid eczema, so it's not usually a first-line test.
Right. So clinical diagnosis first, then targeted tests like swabs or scrapings if needed based on the features, and biopsy or patch testing only occasionally.
That sums it up well.
Okay, let's move to management. This is what patients really want to know. How do we treat discoid eczema?
The main aims are pretty clear. Hydrate the skin, tackle any infection, and calm down the inflammation. It involves a mix of general self-care and prescribed treatments.
What are the absolute basics?
Emollients are crucial. Moisturize, moisturize, moisturize. That's non-negotiable for barrier repair. Then, topical corticosteroids are the workhorse for reducing inflammation. Antihistamines can help manage that awful itch. And of course, trying to identify and avoid any triggers is really important self-management.
Moisturize, steroids for flare-ups, antihistamines for itch, avoid triggers. Seems logical. What about the prescribed stuff?
Topical steroids are definitely the mainstay for inflammation. They come in different strengths or potencies. You might start with a potent one like beclomethasone dipropionate or hydrocortisone butyrate for a flare if there's sign of infection.
The golden crust again.
Right. Then a combination cream with a steroid plus an antibiotic or antiseptic might be useful. Another option for inflammation, especially if you're worried about long-term steroid use, is tacrolimus ointment.
What about really bad cases?
For severe widespread flares that aren't responding well to topicals, sometimes a short course of oral steroids might be needed, but that's used sparingly. And for the really stubborn, persistent cases, immunosuppressants like methotrexate, cyclosporin, or azathioprine might be considered by specialists.
Okay, those are definitely specialist territory. Let's drill down on the basic steps again.
Okay. Rehydrating the skin. Simple things like using cool or lukewarm water for showers, not hot. Patting skin dry gently, not rubbing. And applying emollients and any medicated cream straight after bathing onto damp skin helps lock moisture in. Aggressive hydration is key, even when things seem better.
Keep that barrier topped up.
Exactly. Maintain the wall. For inflammation, topical steroids are the go-to. Ointments are often better than creams because they're more occlusive and hydrating. If infection's present, you need appropriate antibiotics, usually targeting staph and strep. Antihistamines, especially sedating ones at night, help with sleep by reducing that nocturnal itch.
Anything else in the toolkit?
Older, thicker, scalier plaques might respond well to tar preparations. Environmentally, staying cool and avoiding dry heat helps. Sometimes, for chronic cases, phototherapy, light treatment under supervision can be beneficial.
And just to reiterate, immunosuppressants are for those severe resistant cases.
Correct. So a simple way to remember the core management might be HASTE. H for hydration, emollients, cool baths. A for antibiotics if infected. S for steroids, topical usually. T for tar for chronic plaques. And E for environment and trigger avoidance.
HASTE. Hydration, antibiotics, steroids, tar, environment triggers. I like that. Useful mnemonic. So once treated, what's a long-term picture? The prognosis.
It's quite variable, unfortunately. While flares can definitely improve with treatment, discoid eczema is typically a chronic and recurring condition. It tends to come back.
So it's more about long-term management than a cure.
That's generally the case, yes.
Yeah.
The focus shifts to minimizing flare-ups and keeping the skin as healthy as possible between episodes.
And how do you do that? How do you reduce the risk of relapse?
It really comes back to that barrier function. So frequent, liberal, consistent use of emollients is probably the single most important thing.
Keep moisturizing, even when things look clear.
Absolutely. Plus, sticking to those gentle bathing habits, cool warm water, patting dry, applying moisturizer straight after, wearing soft, non-irritating clothing like cotton can help too, and maybe using a humidifier in dry environments, like centrally heated homes in winter.
Okay, so diligent, ongoing skincare is the name of the game for keeping it under control. Lastly, what can go wrong? What are the potential complications?
The biggest issue stems from the intense itch and the resulting scratching. Breaking the skin opens the door to secondary infections.
Bacterial, like staph.
Yes, bacterial infections are common, but fungal infections can also sometimes occur in those broken skin areas.
And infections can cause problems beyond just needing antibiotics.
Yes, severe or recurrent infections can potentially lead to permanent scarring, which obviously has cosmetic implications and can be distressing.
So controlling the itch isn't just for comfort, it's to prevent infection and scarring.
Exactly. Another issue mentioned is that lesions, especially on the lower legs, can be slow to heal. And even after they've healed, they can leave behind brown marks post-inflammatory hyperpigmentation.
Right, and we touched on the impact on the person earlier.
Yes, the emotional and psychological toll shouldn't be underestimated. Living with a visible skin condition that's chronically itchy, that can disrupt sleep, that might leave scars, it can really affect self-esteem, mood, social life, and overall quality of life. It's definitely not just skin deep.
That's such an important point. It affects the whole person.
It really does.
Well, we've certainly covered a lot, from those characteristic coin-shaped lesions to the multifactorial causes, the key differentials, and the importance of ongoing management.
Yeah, I think the main takeaways are understanding it's a barrier problem, knowing those demographic peaks, being able to spot the mimics like tinea, and remembering the haste mnemonic for management, focusing on hydration and inflammation.
For me, the real aha is how central that barrier dysfunction is, linking the dryness, the triggers, the inflammation, and why that relentless moisturizing is just so vital. And, of course, spotting that golden crust as a signpost for infection.
And differentiating it clinically, especially from tinea based on the border characteristics, that's probably super high yield for revision purposes.
Absolutely. Hopefully this deep dive gives everyone listening a really solid handle on discoid eczema. It's worth remembering, too, the broader impact such a visible and itchy condition can have on someone's day-to-day life.
Agreed.
For more free MSRA revision resources, you can visit freemsra.com, and for the full premium revision toolkit, head over to pathomsra.com.